Welcome, and thank you for choosing to attend this session with Dr. Andy Feinberg on the topic of coping with uncertainty and navigating change. My name is Carrie Key, and I will be your moderator this session. A little about me: I am the Camp and Recreation Director at the Siegel JCC in Wilmington, Delaware. I have been a part of the Wellness Summit since the program's inception. First, as an attendee in 2018, after one of our own JCC staff members, Sarah Sagerstrom, died by suicide. After attending that summit, I knew that I wanted to continue the conversation on mental health in order to reduce the stigma. And that's what brings me here today. This session, along with all of the sessions, are being hosted on Zoom webinar. Therefore, you will not be able to take yourself off of mute to ask a question. Instead, please use the Q&A feature. Chat has also been disabled for attendees. After Dr. Feinberg's presentation, we will have a Q&A. If we're unable to get to all of the questions, we will be posting follow-up on our landing page at siegeljcc.org/wellness summit. Without further ado, it is my pleasure to introduce Dr. Andy Feinberg. Dr. Feinberg is an assistant professor of psychiatry and behavioral sciences at the Johns Hopkins University School of Medicine and is board certified in psychiatry. He completed his psychiatry residency and served as chief resident at the Johns Hopkins Hospital in 1985. He spent 3 years directing a mood disorders clinic and medical psychiatric inpatient unit, and then ran specialty psychiatric inpatient units in multiple hospitals in Maryland. For 23 years, he maintained a full-time outpatient clinical practice. His special interests are depression, bipolar disorder, anxiety disorders, geriatric psychiatry, and psychopharmacology. He joined Jewish Family Services in September of 2019 in the Lewis, Delaware office, where he is dedicated to collaborative relationships with his patients, their families, and the referring physicians and therapists. Please welcome Dr. Andy Feinberg.
Thank you for a lovely introduction, and I really want to thank Carrie and Anna, and also Rosie Crosby and Maddie Dreben at JFS for all the technical assistance with my talk. Now I'll get started with my slides. Okay, kind of a, it's a complicated title, but basically we're going to talk about the stress associated with COVID and what that's done to people's anxiety levels, and then what people can do to reduce their anxiety. So here I am with our therapy dog, Iris. Iris has been furloughed from her volunteer activities, and I'll add that we're sitting there outdoors, and what couple of things we're going to talk about in terms of ways of reducing our stress levels and our anxiety levels during COVID. Pets are wonderful for our mental health and physical health, and being outdoors in nature is very therapeutic as well. Iris is watching this, or at least listening, along with my wife, Amy. And not sure whether Amy or our son Daniel took this beautiful photo, but one of them did. So starting with Centers for Disease Control survey, very recently, and whenever we look at a survey or a study, and people who are experts on statistics who are listening will echo this and be nodding that, the more subjects in a survey or study, the better. And here we've got, of these 5,412 adults in the United States who were surveyed, almost 41% reported having at least one adverse mental or behavioral health condition associated with the pandemic. 31% reported symptoms of an anxiety or depressive disorder, and the prevalence of anxiety disorders alone was roughly 3 times that reported during a similar period the prior year. So that gets our attention. that, wow, this is a big problem and something worth talking about. So beyond the physical symptoms associated with COVID, the psychological and behavioral outcomes are vast, and it seems prolonged. And surprising to me, when I first read this, I had no idea that there is a formalized definition of the long-term mental maladies associated with the pandemic, collectively called now coronaphobia. It's a catch-all phrase, meaning it really, when you see something with phobia, I think psychiatrists, I think it's something pretty specific. But this is really a catch-all phrase encompassing, as they say, the fear and emotional and social strain experienced by the general public in response to COVID. Recent literature suggests that coronaphobia may be more likely to occur in those who are more vulnerable to disease or predisposed to anxiety, or who are intolerant of uncertainty. And coronaphobia includes depression and several anxiety disorders, and I'm going to focus on two of the most common anxiety disorders during my talk. My wife and I came up with a list of individual specific stressors associated with COVID. And these are not in any order of priority. In fact, one could say that number 9 should really be number 1. Obviously, so many people have lost their jobs, businesses have closed, and they've got serious financial worries and strain. Depending on how one's tolerance for challenging the safety of our own safety, some people are going to stores and shopping for food and some aren't. But even those going to stores being safe are finding that a lot of things are in short supply or stores out of them. And that's stressful. Where am I going to get these things? People are more isolated from family and friends, and we need, as we're going to see down the road in the talk, we need company, companionship, conversation. Very, very good for our mental health, and people are missing that. We're way more isolated than they were. And this number 4. Depending again on what you're able to do in your community, but some things that we can't go to that we all miss. Many aren't able to travel safely, and certainly I think we all know of families who have had to cancel or postpone major celebrations and memorial services. Something my wife thought of, that now if you go with your partner or with your pet to see a doctor or veterinarian, you can't go in and just have a good conversation with the doctor about your pet or about your loved one. And that makes communication more difficult and stressful. Many of us, myself included, are now working from home, and although there are many conveniences that come along with that, there are certainly distractions that we didn't have when we were going to our place of work. And people who are home, who have young children, who are doing schooling remotely, there's plenty of stress and distraction associated with that as well. I was reminded when my wife and I visited a dear friend of JFS who lost her husband recently, and we visited safely outside on her patio, just the 3 of us. Of course, Iris was with us, and I realized this is a very good, gregarious woman who counted on having lots of company and stimulation and support, and she's missing that deeply. And of course, all of us are, especially with the election approaching, there's too much and all that else that's going on with COVID and racial tension in the country, plenty of disturbing, overly stimulating news on TV that is contributing to people's stress level. I love this cartoon. I routinely do rating scales when I interview someone with an anxiety disorder and rate their anxiety, and then we compare. And it's cute to see that, although these are strongly genetic conditions, the daughter looks like she's doing pretty well. Mom looks okay. Dad looks like the worried one. He's rating his anxiety level. Definition of anxiety: it is a feeling of worry, nervousness, or unease, typically about an imminent event or something with an uncertain outcome. And we've got on our hands an ever-present imminent event and a very uncertain outcome, no light at the end of the tunnel, sadly. Yeah. Where does the word anxiety come from? Well, it comes from the Latin word anxietas, which comes from an earlier Latin word, angere, which means to choke, which I think is interesting. So there is what we would call normal anxiety. I put normal in quotes because having done psychiatry for as long as I've been doing it, it's hard to define what normal is. But this could be just common situational anxiety, and as it says, associated with an identifiable stressor, and it's expected to resolve when the stressor is gone, meaning the stressful event is over with and the anxiety ends. It doesn't take on a life of its own. Common physical symptoms of anxiety that I think all of us are familiar with: headaches, nausea, shortness of breath, shakiness, gastrointestinal discomfort of one kind or another. And this is what we've learned all way back when, the fight or flight reaction. And we're going to look at a very nice schematic drawing of a brain and these parts of the brain that I'm going to mention in passing now. We have, in fact, I'm going to go forward and then back. We have our brains, or in our skulls, we've got three brains, basically. We've got a very primitive reptilian brain in this part. Then we've got a pretty primitive mammalian part of the brain called the limbic system. Okay, now I did my grad school research before I went to medical school. I did research on rats' brains, and let me tell you, rats have a very nicely developed limbic system. Now we're different in that we've got this cerebral cortex overlying the limbic system, and it is supposed to exert control over some of these centers, and sometimes it doesn't do such a great job at that. So if we can go back, so the amygdala, which we're going to see again in the drawing, amygdala in this limbic system is the highly reactive, emotionally reactive part of our brain. That gets activated when we perceive a stressful situation. And then other parts of the limbic system become activated, including the hypothalamus, which is an amazing part of the brain that regulates all kinds of things, and hunger and thirst and libido and things of that sort, temperature regulation. The hypothalamus connects to the pituitary gland, which sits at the base of the brain. And from the pituitary gland, and from activation of another part of the nervous system called the autonomic nervous system, the adrenal glands sitting on top of our kidneys release the stress hormones we're familiar with, adrenaline and cortisol. And again, the diagram of the brain, there's the amygdala, and remember, in real life, they're not these pretty colors, obviously, but there's the amygdala, the hypothalamus, and here the pituitary gland, and anything else and there's, of course, the cortex. And we know, as we get into talking about the anxiety disorders, the signals that are supposed to be coming, inhibitory signals from this part of the brain in the front, right behind our forehead, supposed to inhibit unnecessary reactions from the amygdala. And in anxiety disorders, those signals, inhibitory signals, are not working right. With psychotherapy and medication, the signal is improved, and people find they're way better able to control and inhibit the amygdala reactions. So there's a gray area between normal reactions to stress and what we consider pathological anxiety or anxiety disorders. But here we're going to talk about the disorders next. First, generalized anxiety disorder, or GAD for short. And this one is chronic, meaning that it's there all the time. It's not episodic. It's not situational, although it can be worsened in situations. Usually begins in childhood. You ask people, when they come in, talk about their chronic anxiety, when did it start? And many people will remember, how early in their childhood it began. Heritability. Heritability is the percent of the total risk for getting a condition that we can attribute to genetics, to one's genes. And for GAD, we see 30%, which is considered significant. But you could say, well, 70% is not genetic. And there is work being done around the world, in Australia and in the US, taking mothers who have an anxiety disorder, who inadvertently, through how they're handling their babies, are actually increasing the child's risk of ending up with an anxiety disorder. And in these clinics, they're actually teaching the mothers how to handle their babies differently, being less protective, for example, to reduce this child's risk of ending up with an anxiety disorder. So how do we make a diagnosis in psychiatry today? Well, we've got a book called the DSM-5, the DSM, the Diagnostic and Statistical Manual, and it's the 5th edition. I remember all the way back to the 1st edition, which was very small, and now it's a very big, thick book. But it's a wonderful reference and resource. And they get together experts, world-famous experts in any condition in psychiatry, get them together and say, well, you folks, men and women, come up with what you think should be criteria for making a diagnosis of this condition. Then they do field testing to validate the list, and they end up with widely accepted criteria. And you say, well, if somebody meets these criteria, they have the condition. So their criteria for diagnosing generalized anxiety disorder include excessive anxiety and worry. And surprisingly, adding that important symptom, worry, that came pretty recently. And people were, way in the past, the person's a worrier by their personality. And then you say, well, I don't know. Now we're saying excessive anxiety and worry occurring more days than not for at least 6 months about a number of events, not just worried about one thing. Person has difficulty controlling the anxiety and worry, and the person experiences 3 or more of the following additional symptoms: restlessness, being easily fatigued, difficulty concentrating, irritability, muscle tension, and sleep disturbance. So if you have 3 of those, you have excessive anxiety and worry occurring more days than not for at least 6 months about a number of events, you have trouble controlling it. So far, you've got GAD. But then they say, well, it's not better explained by another psychiatric condition. And that's there because a lot of people who have depression, clinical depression, become severely anxious along with their depression, but it's episodic. When their depression's gone, their anxiety's gone. Some people have both depression and an anxiety disorder. And then, boy, it's a good thing that our current medications, which we're going to talk about very soon, work for both very effectively. And the symptoms, another criterion is the symptoms cause significant distress and impairment in important areas of functioning. And that's very important. and that's in DSM-5. Something like that is in the criteria for nearly everything. And you have to be able to show that a person's anxiety is not caused by drugs. What kind of drugs? Oh, drugs that are overly stimulating, including caffeine. Medications that could be someone's thyroid medicine, for example, if the dose were too high, could cause anxiety, and other physical conditions that can present with anxiety, like overactive thyroid. Treatment. What do we do for people with generalized anxiety disorder? Well, combination of, at least the combination of psychotherapy and medication has been proven to be the most effective and the longest lasting successful kind of treatment. And we will have therapists talking as part of this conference. And so I'm going to focus on the medications, the things that I know best and you do practice all the time. So we've come a long way. You know, there are fast-acting medicines called the benzodiazepines, which work very well for anxiety, but there are a lot of problems with them. They're good for short-term severe situational anxiety. They should not be taken long-term. People can develop tolerance. They are abusable, can be highly addicting, and we're trying these days to really limit their use. Far better are, and safer are most of the modern antidepressants. Everything since Prozac in 1987, the so-called SSRIs or selective serotonin reuptake inhibitors, are all wonderful for this condition, as well as depression and other anxiety disorders. There are serotonin norepinephrine reuptake inhibitors, Cymbalta, Effexor are common ones. They're very good for this also. The older antidepressants, pre-Prozac, the tricyclic antidepressants, the MAO inhibitors. MAO inhibitors are tricky ones to use, but they are used occasionally. But the tricyclics, good for panic attacks, but not for this kind of anxiety. So we really stick with the SSRIs or the SNRIs, or a couple of other medicines that aren't approved for these conditions, but that are safe and effective and are widely used. A drug called Neurontin or gabapentin and its cousin Lyrica. Here is a painting by The Great God Pan by Norman Mills Price, and I love the painting. He's in a beautiful setting, and again reminds us of how calming and therapeutic being out in nature can be. We see beautiful birch trees and cattails and lily pads in the water and a couple of tree dandelions thrown around. And he looks like he's having a very good time, and he's about to blow his pipe, but he has an interesting expression on his face. By the way, Norman Mills Price was a Canadian-American artist who ended up in New York City. So he's there because the word panic comes from Pan, the pipe-playing Greek god of fertility, pastures, flocks, and shepherds. But as you see, and when I commented on his facial expression, he had a dark side. His shout instilled fear in the giants who were fighting the gods. So that's where the word comes from. And heritability, we see higher than for generalized anxiety disorder, even more strongly genetic. In fact, panic disorder was historically the first psychiatric condition that we knew was strongly genetic, occurred in families commonly. Again, the DSM-5, these are the criteria for panic disorder, and we see recurrent, unexpected panic attacks, meaning just spontaneous, not situational. With 4 of the following, we'll see the physical symptoms, palpitations, chest pounding or feeling your heart skipping a beat, sweating, trembling, shortness of breath, feelings of choking. Remember the the origin of the word anxiety. Chest pain, nausea, and chest pain. Many people first time around with a serious panic attack fear they're having a heart attack and they're going to die, and they end up in emergency rooms and they get a full cardiac workup, which is hopefully negative, and then the staff say, okay, now this is probably a panic attack. And if you have a series of them, and I mentioned these other common physical symptoms, feeling detached, losing control, going crazy, all these things that people have when they're having a panic attack. And they also develop apprehension, great worry and anxiety about having another panic attack, and some avoidance. And there is a condition called agoraphobia, which can result from panic disorder. Agora, a Greek term for marketplace. So a fear of you have a panic attack in a place and you're out and you say, oh my gosh, I better not go back there. I might have one again and be embarrassed by my behavior during the panic attack. And then gradually people can withdraw and I can't go here or there and end up confined to their homes, which is pretty serious and requiring good behavioral therapy program as well as medication. Again, another criterion for this is not caused by another mental condition. And again, people can have panic attacks when they're in a depressive episode, not have any other time. They would not be defined as having panic disorder. Treatment again, combination of psychotherapy with a behavioral focus and medication are the very best you can do anywhere in the world, I believe, at this point. So what are the medications we use? Some of the very same ones, most of the very same ones we use I mentioned, for generalized anxiety disorder, the SSRIs, the SNRIs, perhaps gabapentin or Lyrica. These are very, very, and a couple of others too, but they're very, very effective. And what we'll do when someone first comes in, we'll say, well, describe the attack, how long does it last, typically, how often you're having them, and then with treatment, we say they're less frequent, they're milder, they're shorter. Eventually, people can expect to not have any, and this is a very easily treated condition. So some people react to situational stress, particularly ongoing stress, such as we are all under, in what we call maladaptive or unhealthy ways. And a Nielsen survey looked at alcohol sales, and they were up 54% in late March compared to the same time last year. Online sales were up nearly 500% in late April. I think that's amazing. And then another poll, 2,200 adults, a nice sized group, in early April showed 16% were drinking more during the pandemic. I remember very well early in the pandemic when there was more of a shutdown in Delaware, and they mentioned alcohol sales. And I remember on TV that someone interviewed owner of liquor stores were considered essential services and businesses, and they were allowed to stay open. And they interviewed a proprietor of a liquor store. He said, yeah, he chuckled. He said, yeah, many people I hear are treating their anxiety with wine. So there we are. Then according to a study published in the Journal of Addictive Disorders, medical cannabis users or medical marijuana users with mental health conditions reported a big increase in their cannabis use since COVID began, increasing their use on average by 91%. And that greatly disturbs me for a couple of reasons. One is that they're muddying the water. They should, with their marijuana, they really should be contacting their mental health team to say, I think maybe we need to adjust the dose of my medicine because I'm not doing well in this pandemic. And marijuana has, probably the CBD component of it. If once we figure out, do the proper research, which I'm sure is ongoing, we'll find that CBD may have a role in helping people with anxiety when it's approved and when we know the proper dose way down the road. THC, on the other hand, the other major component, can be harmful for people with psychiatric conditions. And according to the New York Times, October 11th, thanks to the stress of COVID-19, social unrest, and the election, all these stressors that we're undergoing right now, cigarette sales are unexpectedly high this year. And a company formerly known as Philip Morris said that the surge in cigarette sales is reversing what was a very nice long-term decline in tobacco sales. So these are not healthy ways of dealing with the stress from the pandemic. There are much healthier ways. I know others, therapists, are going to be talking about resilience, and from the American Psychological Association, some reminders of things that are very, very important and therapeutic. One being trying to build and maintain your social connections, even if it means on FaceTime or Zoom rather than live. Fostering wellness, there's taking better care of yourself, meaning getting enough sleep, exercising, not drinking too much or using drugs. These are things, and finding purpose in your life, especially for people who are at home, who are not working. Structure, volunteer activities, doing for others. It's very, very good for us mentally. Embrace healthy thoughts. People who are stressed, who are prone to anxiety, or prone to negative thinking. And this is just a reminder, as the good therapists that we meet they're focusing on something called cognitive therapy or cognitive behavioral therapy, CBT, which teaches ways of reducing negative thinking and substituting positive thinking, which is very beneficial. Embrace, and then of course, seeking help. If you're in the gray zone, I don't think I have an anxiety disorder, but my anxiety is getting pretty bad. I think I need to see someone for help, and seeking therapy is a wonderful idea. I think the JFS model, where one who's referred first sees a therapist, I think is brilliant. And then if the therapist thinks, I think Dr. Feinberg needs to take a look, then they will call me in to see what I can do. But starting with a therapist is also always a very, very good way to go. And to a longer list of things that we can all do, specific things that are very helpful during these times. Exercise, many, many good studies showing its benefits for anxiety, for depression, for stress reduction, and remarkably for many other physical conditions. For men, moderate frequent exercise can actually reduce the risk of prostate cancer by up to 70%. I think that's pretty impressive. Mindfulness techniques, which I know others are going to discuss and talk about, ways of focusing more on the moment and trying to tune out external things that are worrying you and weighing heavily on you. Psychotherapy, again, which has many, many components, and most good therapists will try this for this person, see if it's helpful. If it isn't, I try something different, and being able to shift gears. Yoga and Tai Chi, both very well studied in the mental health field, very healthy for us, both physically, and they're mindfulness techniques as well. Interactions with nature, as I alluded to very early on. There's a professor in Seattle, University of Washington, Peter Kahn, whose entire work is focused on research showing the beneficial effects of interactions with nature for people. And there's plenty of good work on that. Prayer, for those who are so inclined, very helpful. Hobbies and creativity, and of course this would include reading, getting back to music, art, all these things that are very good for us. Gardening. Pets, and mentioned at the beginning, pets are wonderful for us for mental and physical health, and a reason why, thank goodness, a lot of the shelters are drained of, usually empty, they're usually full. And catching up with movies, I don't mean to downplay TV. There are a lot of good things on TV that are relaxing, that can take us away from all the stress. And there we are again, Iris and I, and outdoors again. And here's the reminder that I was in the Lewis office, but now working remotely, as we all are in that office, therapists as well. And there's how to get in touch with us for if you do need help. So thank you. And now we'll have time for questions.
Thank you, Dr. Feinberg. We do have a few questions asked by some of our listeners. So the first one was, I wonder how best to find a good fit with a therapist. What recommendations do you have?
It's a great question. There was one of my professors at Johns Hopkins who's been long gone, Jerome Frank. He was emeritus, quite an old guy when I was there in my training. He'd done research on psychotherapy. He's a psychiatrist interested in psychotherapy. And his conclusion is a good old book called Persuasion and Healing by him. But he concluded that the most important piece to the success of psychotherapy is the nature of the therapeutic alliance, meaning that this has to be, when you're looking at therapists, and I've seen people who, in the field, have said, well, this wasn't a good fit. I'm going to need to, and I always say, well, try somebody different. It's like with medications. It might be trial and error. But I always ask people when I'm referring them to a therapist, do you have a gender preference? Some people might. Is that important to them? Is the age of the therapist important to them? But mostly it's going to be someone who you think is a good listener, who is really listening to you, you can really feel comfortable talking to and connecting with.
Great, thank you. Our second one, I hope that I can pronounce this one word properly. What does gabapentin do to the brain to minimize anxiety? And how does it affect the amygdala?
It's interesting. Well, how does it affect the amygdala? You got me. But in terms of the brain chemistry, it affects the GABA system in the brain chemistry. The brain has numerous chemicals called neurotransmitters, and our meds work differently on the different brain chemicals, and without having the benefit of being able to do a scan or a test of any kind, they'll say, oh, your GABA system is awry, so you need this. And we can't do it. We don't have that. So it's really trial and error, saying, well, if a person didn't do well in this drug, didn't tolerate it well, let's try something different. And but that's the most we know about it.
Okay, thank you. And if you have a mental health condition that is anxiety provoking, when should you just wait and see if the increased symptoms will pass? And when should you call your care team for additional help?
These are great questions. Okay, well, one problem we have is that the antidepressants that we use take a while to work. So they take at least a couple of weeks to work. So, I'll start somebody on a medicine and say, well, see you in usually about 3 weeks. Say, well, let's give it time to see what it's really going to do. So, people need to be instructed that, number one, it's going to take a while to work. Psychotherapy takes a while to work. So combination will help, but it's going to take a while. But if one's symptoms worsen between visits, one should be comfortable calling. And, we have a nice, wonderful system in JFS where people can call me, get hold of me between visits. And I call Rose and she gets hold of me by email. And I say, all right, give her a call. Maybe we need to do a little dose adjusting between the visits. So, and certainly people who have been stable on a given dose of a given medication or a combination of medications who are now in this setting of COVID worse, their symptoms are back. Well, we say, well, okay, maybe we need to do a dose adjustment or try something different.
Okay. If you are depressed and anxious, it is difficult to get yourself to try some of the activities that the doctors listed. How do you suggest to get started?
Boy, that's a tough one that I deal with every single day with patients. And that is, I tell people that, of course, the worst thing about depression is sadly that some people with it do kill themselves, and that's tragic. I think the next worst thing about depression is that it takes people away from the very things they love that are so good for them and the people who are so good for them. And it's very, very challenging until a person starts to feel better. Okay, then we jump in, say, when they say some improvement, and well, how about, so a woman today who says, she's probably, since I've been at JFS, the most serious case of depression that I've seen, and she's finally getting better after trials of probably 7 or 8 different medications. Okay, it's finally better, and it just warmed my heart today when she said she was actually looking forward to going to hit some golf balls with her husband. So, and once people get back to doing those very things, it accelerates the improvement from the treatment.
Okay. Is it possible to manage these anxiety disorders without medication?
Yes, absolutely. And there are people who I've seen who said, gosh, I appreciate your diagnosis and your recommendations. I'm really not interested in trying medication. And I tell them, look, I rarely twist arms. Someone is in the depths of depression and I think at risk for suicide and not eating, I twist arms. But anxiety disorders, that person is otherwise fairly functional. Say, no, try good psychotherapy. Try these other techniques that were mentioned on my list. Make sure you're exercising. Go start doing yoga. All kinds of things. Get a pet. So there you are.
All right, and our last question was, how long should someone with an anxiety disorder stay on an effective medication?
That's another one. Good one. Well, we don't have any good answers to that yet. Sadly, it's amazing. I think we would by now, but we don't. And so I kind of extrapolate from the depression work where we know, if you have a single first episode of depression, you get better on a given dose of a given medication or a combination of medications, and you're well, then you should stay on those meds or that medicine, that dose for a solid year without even thinking about lowering the doses or trying to come off the medication. And studies have shown that there is lasting effectiveness in terms of protection down the road in the rest of your life against further depressions if you stay on it initially for a good solid year. So I just thinking the same common sense in the brain chemistry, and if it takes that long for lasting effects to take place in the brain, I tell people the same thing for anxiety disorders. And then I'm flexible. You say, well, at that 1 year point, what's going on in your life? How are things going? Are there things on the horizon that might make us say, well, it's kind of arbitrary, this 1 year point, maybe we stay on it a little longer, or people might be, no, things are going well. And always taper the medications carefully. Go down slowly on the dose, just in case your symptoms come back. And because people have trouble, some folks do, coming off these meds abruptly anyway.
There was a follow-up question dropped in here. Do anxiety medications develop tolerance?
The benzodiazepines I mentioned at the beginning, Xanax, Ativan, those drugs, Valium, they do. And that's one of the problems with them. The antidepressants, no. Sometimes it might look like that. But if you really ask the right questions and look around and say, well, it's that, the medicine was working fine. Now the person's under a great deal more stress than they were. And it's breaking through, for that reason, rather than real tolerance. People don't develop tolerance to antidepressants.
All right.
And yeah, I think, and I should mention too, that there are people who don't want to try a prescription medicine, but there is work on a few of the herbal products that can be helpful when dosed correctly. Chamomile is one.
Okay. There's another follow-up question to that last question. Is there harm in staying on an antidepressant long-term?
No, there isn't. And some people who have had, chronic condition, and we say, God, my golly, if you've had chronic depression, for example, you've had a very agitated and suicidal depression, and you're now doing well, we would say, don't think about coming off this medication, probably long term. There are really very few things to be concerned about staying on these for years and years and years. Prozac's been out, as I said, since 1987, and there are a lot of people around the world who have been on it ever since, very safely. These drugs down the road in the older people who are more sensitive to side effects to begin with, might bruise more easily. There is another unusual condition where people have a little trouble with their kidneys, nothing serious, something easily corrected. But no, those are very unusual. These are very safe medicines to stay on long term if you need to.
Okay. It looks like, can medications for depression help with sleep disorders?
Absolutely. In fact, when someone has a sleep disorder or sleeping problem, insomnia problem, it's very important to figure out what's causing it, if you can figure it out. There are a lot of sleep disorders that are treatable, and people should be aware of that. Sleep apnea is very common and easily treated, for example. But a lot of people with depression have insomnia, and a lot of people with anxiety disorders have insomnia. And either difficulty falling asleep or waking way too early, not getting enough sleep. And treating the depression or the anxiety disorder will improve their sleep. We do have some antidepressants that are more sedating than others. And some people need something a bit more sedating for their condition that will help them sleep. And if somebody's sleeping better, it's good for what ails you. So.
Okay. We have a comment here that just says, excellent. I love the person-centered view. I appreciate the reminder that not all therapists are a fit. So that was just
Great.
Nice to see their feedback. Well, that was our last question. So thank you so much, Dr. Feinberg, for your time today. And just a reminder to our participants, anything that we did not get to will be put on our landing page. We hope that you can join us for upcoming sessions tonight and over the next 2 days. Tonight at 6, we have Pilates with JCC instructor Kathleen. And then following that at 7 p.m., we have Jennifer Smolowitz from the Mental Health Association of Delaware. And she'll be talking about holding on to hope, suicide prevention during challenging times.
Thanks.
Thank you.